Welcome everyone. My name is John Franco Froyo. I am currently a potentially fourth year medical student, almost done, at the University of Alabama at Birmingham School of Medicine. This is a very high-yield section of the Cardiovascular First Aid chapter. This is because examiners have the ability to present a clinical vignette and then test you on the fundamentals of embryologic development. Cardiology is one of the select chapters in which understanding a handful of fundamental embryologic and physiologic concepts can take you a really long way, especially in understanding pathology and pharmacology that relates directly to the development of the heart. So please make sure that you have a solid grasp of the material that's going to be presented in this section. It takes students a lot of time and practice, including myself, to really master these concepts, so please be patient and I'll help to do my best to present these concepts to you in an interactive and memorable way. Along the way, we will also use mini flash quizzes, questions, and vignettes to help test your understanding, and hopefully by the end you'll have a better sense for the board relevant topics in the cardiovascular embryology section and how to apply them on your exam. So this is a recreation of the chapter table as listed in your first aid book. It should serve as a helpful tool to memorize the embryonic derivatives of the adult structures in the heart. I'm going to present this table here just for the individuals who prefer to see the information tabled. Don't worry, these structures will all be discussed in the coming slides as part of the development of the heart. You can revisit this table at the end of the discussion of embryology to review some of the high-yield references in embryologic derivatives. Okay, let's begin with the development of the heart. This is especially important since the congenital heart diseases are due to improper development somewhere along this process. The heart begins as a simple tube lined with endothelial cells and myoblasts. This makes a lot of sense because endothelial cells line the endocardial surface and the vasculature associated with the heart, and myoblasts are necessary for the development of the myocardium. It begins as a simple tube lined with these cells, but its structures develop into a more familiar form of the mature heart here by 7th week. Do you remember which week of development the heart actually starts to pump blood? That would be the 4th week. I remember that because we need 4 chambers to adequately accept and pump blood throughout the systemic circulation. Even though there's no 4 chambers fully developed by the 4th week, I like to remember that because the normal heart has 4 chambers and it pumps blood when it has those 4 chambers. But in the fetus, it starts pumping blood before there is 4 chambers completely separated. The important component of this slide is to notice how there is a change in the structure of this heart tube. The most superior aspect of this tube will come down out of the screen and bend towards the right, while the inferior aspect starts to go into the screen and superiorly. This makes the bulbous cordus into an S-shaped structure. So again, the top part of the tube bends out of the screen towards you, and the left side of the tube goes into the screen and bends superiorly. Why do we do this? Well, it makes the bulbous cordus become a segment that is kind of shaped like an S. What is very important here to understand is that bulbous cordus is composed of 3 segments: distal, middle, and proximal. Before I tell you what is going to happen with these segments, let's quickly just make sure that we understand what's going to happen with them as the end result, and then we'll go further into the process. So the proximal portion, so the distal, middle, and proximal, the proximal portion is really close to this ventricle. This is the primitive ventricle eventually. So that means that this will become the left side. We need something to become the right side. As you can see, as this bulbous cordus is coming down this way, you will have a segment that is most proximal, close to the original ventricle, which will become the trabeculated part of the right ventricle. The middle segment will form the outflow tracts of both ventricles. And this is due to the fact that there's an atrioventricular canal that is eventually split into 2 that becomes the outflow tract. So it goes straight down this middle segment of the bulbous cordus, and that's why you get outflow tracts of the right and left sides from it. The distal part, even though it appears to be different, actually gives rise to the truncus arteriosus. So the image may be misleading, and it's that way in a lot of textbooks, but the distal portion of the bulbous cordus actually becomes the truncus arteriosus. The middle segment becomes the outflow tracts of the right and left ventricles, and the proximal segment becomes the trabeculated part of the right ventricle. Now, how this happens we can discuss in a second. So as we can see, there's this continued rotation of this cardiac loop that's bringing the bulbous cordus into the more anterior and right side with reference to anatomic position, while the left atrium has swung more superiorly and posteriorly, which makes a lot of sense because the left atrium is the most superior and posterior structure of the heart. Again, we said that the bulbous cordus is composed of a distal, medial or middle, and proximal segment. The distal segment will give rise to the truncus arteriosus. A truncus arteriosus will give rise to the ascending aorta and the pulmonary artery, which makes sense considering it is making the trunks of the two main arteries in the heart, hence the name truncus arteriosus. So it makes the ascending aorta and the pulmonary trunk. This is further shown in this diagram, where the distal segment of the bulbous cordus became the truncus arteriosus, and then the truncus arteriosus develops the two trunks of the arteries in the heart, the pulmonary artery and the ascending aorta. Now, what about the mid portion of the bulbous cordus? As you can see, it becomes the conus cordus. Why do they call it the conus cordus? Well, the outflow tracts which the conus cordus makes are cone-shaped because their job is to funnel blood to a more narrow flow vector so that we can pump it very efficiently out of the heart. I kind of remember this because a funnel is cone-shaped. Just like the smooth part of the bulbous cordus called the conus cordus. This is important to remember. This is the smooth part because you need smooth laminar flow for outflow tracts. Finally, the proximal third of the bulbous cordus become what? What position does it seem to be sitting in? It seems to be sitting in the position of the right ventricle, and it will become the trabeculated part of the right ventricle. It will balloon out, and you will eventually add trabeculations. The diagram here is misleading because it seems like the left ventricle is becoming the trabeculated part of the right ventricle, but do not let that mislead you. The bulbous cordus proximal segment becomes the trabeculated part of the right ventricle. We will discuss further this left ventricle in a second. What is important to notice is that there's going to be a junction between the proximal segment of the bulbous cordus and the primitive ventricle. Primitive ventricle becomes the left ventricle. What is this narrow junction between what becomes the trabeculated part of the right ventricle and what becomes the left ventricle? Well, this little segment that does not expand out kind of looks like this. This is the bulbous cordus, the proximal segment becoming the trabeculated part of the right ventricle, and then our primitive ventricle becomes the left ventricle, which is represented at this part of the diagram. So both of these structures balloon out while this little middle segment did not do anything. This is a small communication that we now have between these two ventricles. That's why it is called the interventricular foramen, which you can see on the exterior surface of the heart as the interventricular sulcus, because there's a narrow connection here, and this will be readily visible as an indentation on the pericardial surface of the heart as the interventricular sulcus. So from the last couple of slides, we've seen a bunch of arrows going up and down. You kind of notice that there was a lot of movement. The heart tube initially looped down and to the right, out of the screen, and up into the left end of the screen. Do you remember a condition from biochemistry that has something to do with an abnormal heart position in the thorax? Well, we were thinking Cardiovascular's syndrome. You absolutely destroyed that question. This is also termed primary ciliary dyskinesia with situs inversus because there's an abnormality of the cilia that does not allow proper movement of the heart in this position. Instead of the heart tube going down and out of the page, and also left and into the page superiorly, there is no movement like this. It just remains where it was sitting in the heart. It remains where it's sitting in the thorax. So instead of the left ventricle being positioned on the left side, a bulk of the heart will just remain on the right side of the chest. This is why you get dextrocardia, which is dextro means right and cardia obviously means heart. So someone with Cardiovascular syndrome has symptoms of impaired ciliary movement, which can affect the bronchopulmonary tree and any sort of structure that requires cilia for function. Particularly high yield would be to know that they can be infertile because the movement of sperm after the completion of spermatogenesis requires cilia. Now, that was a really complex process. It has always been hard for me to understand embryology, so I admire you guys for toughing through that. Let's discuss some of the venous structures and their derivatives. An important point to make is that the formation and positioning of the venous structures are directed by retinoic acid. Anyone that's ever taken retinoic acid knows exactly where I'm going with this. Development of these venous structures are signaled by this compound on your page. retinoic acid. Why is this important to us? If you recall back when you studied teratogens, which drug can cause heart defects that has a similar molecular structure to retinoic acid? If you said isotretinoin, then I admire you. No way I would have known that when I was preparing for step 1. This is a way that you might see some different sections tied together on your step 1 exam. For example, you might receive a question like, an 18-year-old female forgot to take her birth control medication prescribed by her dermatologist while receiving therapy for her cystic acne. She is concerned that if she becomes pregnant, her fetus will have heart defects due to blank. And the answer will be something like the inhibitory action of isotretinoin, and that's it. You know the embryology, you can answer the questions. So the image on this slide seems kind of intimidating, but it will be helpful for us to understand how things end up developing. It is the circulatory system in the 4th week. Remember, that's when the heart starts pumping. Why am I showing you this? Well, it has some of the important derivatives that were on the chart we saw on the first slide. If you can visualize them, then you'll probably be able to remember them much better. So, as you can see, there's the anterior cardinal vein. It is named so because it's one of the primary veins that we form. Just like the anterior cardinal vein, we have the common cardinal vein, which is the union of the anterior cardinal vein with the other veins that are returning to the heart, such as the posterior cardinal vein and the umbilical vein, the most inferior aspect. So do you see the anterior cardinal vein feeding into the common cardinal vein? It kind of looks like it is feeding into the superior portion of the heart. What do we call the large vein that drains into the right atrium at the superior part of the heart, kind of in the same position that I just circled on your screen? Superior vena cava. The superior vena cava is derived from the anterior cardinal vein and the common cardinal vein, and this should make perfect sense to you because they're coming together to drain to the superior aspect of the heart. And the structure here will be the right atrium. Can you see here on the image where the common cardinal vein, the vitelline vein, and the umbilical vein all meet up right before they go into this tiny heart? This is the venous drainage into the heart. What would you call this space here where all of these venous fetal derivatives drain? I'd probably call it a sinus because it is one big chamber where all the venous blood collects. Guess what the early anatomists called this structure? Well, it's draining the venous structures. It's a sinus-like chamber. They called it the sinus venosus because the blood from the anterior cardinal vein, the common cardinal vein, and the umbilical vein all drained into it. The sinus venosus is a structure in the embryonic heart that initially receives all of the venous return from the tiny venous circulation. So when this heart develops into the mature heart, do you think its function will change? No. That would be incredibly inefficient. It will continue to be associated with the receiving of venous blood. Nature does not like inefficient processes. If it's in this location, it's probably going to remain as a structure functioning in that location in the future unless it degenerates. So what do you need to know about the sinus venosus? You need to know 2 things. It is split into 2 horns. And a horn is described so because it has the presentation like this. So this is the sinus venosus, and this is a branch, and it kind of looks like horns when early anatomists saw it. They are just branches of veins that drain into the sinus venosus. Obviously, there's a left and a right. The left horn will become the structure that will receive venous blood from the coronary veins. This makes a ton of sense because the coronary sinus runs from left to right on the posterior surface of the heart. So you better believe you can make the connection that it probably came from the horn of the sinus venosus that was running from left to right on the posterior side of the heart, which is the left horn of the sinus venosus. What about the right horn? The right horn of the sinus venosus is on the right side of the heart. Wow, huge, mind-blowing moment there for me. Yeah, it actually was, because it makes a lot of sense now. I don't even have to memorize it. I know that the right horn of the sinus venosus is on the right side of the body, so it's probably going to make a structure of the heart that's on the right side. It becomes incorporated into the atrium to form the smooth part of the right atrium. Makes a lot of sense, doesn't it? It's connected to the anterior cardinal vein and the common cardinal vein, the posterior cardinal vein, and the umbilical vein. It should probably be doing something helpful to make that laminar flow that we need to return blood to the right atrium. And that's what it does. So again, 2 horns, left and right. Left is on the left side of the heart. On the posterior side, it becomes the coronary sinus. The right is on the right side of the heart. It actually becomes the smooth part of the right atrium. The last structure in the chart that we saw in the first PowerPoint slide was the primitive pulmonary vein. This is an easy one to remember because blood needs to enter the left atrium with laminar flow, just like the right horn of the sinus venosus made laminar flow by becoming the smooth part of the right atrium. So the pulmonary vein incorporates itself into the left atrium, and that's why it becomes the smooth part of the left atrium. Which structure drains newly oxygenated blood into the left atrium? Pulmonary vein. So the primitive pulmonary vein better get its act together and be real smooth, because we want that blood flow going into the left atrium from our lungs to be laminar and nice and smooth to ensure that oxygen is being delivered from the lungs for systemic delivery.